We'd like to thank everyone for joining the webinar today. It's sponsored by the Minnesota Gerontological Society and the University of Minnesota Center on Aging, MAGIC. MAGIC is the Minnesota Area Geriatric Education Center. My name is Tom Hyder, and I'm going to be the moderator for your session today. I'm the Executive Director of MGS. More details and information about upcoming webinars can be found on MGS's website, mngero.org. If you go to our website, then go to the webinar page, you'll find links to the information that will be discussed in today's webinar and information on many of the past webinars which are presented monthly. I'd also like to thank all of you who attended the MGS annual conference last month on April 25th. The theme was Preparing the Workforce for an Aging Society, and there were over 300 in attendance. Mark your calendars for next year's conference. It's going to be held on April 24th, 2015. Since you joined the webinar today, your email will be on our list and you'll receive many updates about that. Now, a few logistics for today's webinar. We now use the GoToWebinar platform to offer these webinars to you. This is our second webinar using this technology, and it will hopefully provide you with excellent audio and video quality. If you're having issues hearing the presentation, you have the option of either using your computer speakers or the phone. If you'll notice on the right-hand side of your screen in the drop-down box, you can switch between phone and your speakers. Your conference audio is muted, so if you have a question for the speaker, please feel free to type your question in the chat area or the question area in the drop-down box on the right. I'll be monitoring the questions and I'll ask them of our speaker toward the end of the presentation. If you have to leave the webinar early, just close your browser and hang up your phone. Immediately after the webinar today, an evaluation will pop up on your screen. We're interested in learning what you liked, what you didn't like, and what you think we can do better, and especially any future topic ideas. Also, if you want continuing education credits for today, you must complete the evaluation and indicate your interest there. We're also recording this webinar, and for MGS members, you can go to the MGS YouTube channel and watch the recording at your pleasure. We're very pleased to welcome our presenter today, Marty Barnum. Marty currently works as a consultant and an interpreter. She recently spent a year with the Office of Ombudsman for long-term care under a special contract to look at the needs of nursing home residents with hearing loss. Ms. Barnum previously coordinated interpreter services for the state of Minnesota, taught at St. Kate's University, and provided advocacy services for deaf, hard of hearing, and deafblind people in medical and legal situations. Thank you, Marty, for presenting our webinar today about this very important and timely topic.
Thank you, Tom, for that wonderful welcome, and welcome to everyone out there in webinar land. I'm pleased to be here today. As Tom mentioned, I'm currently doing consulting and some interpreting work. I've worked as a sign language interpreter off and on since 1978, and that's what the CSC means under my name, is my Comprehensive Skills Certificate. I worked a couple of years ago for a year under a special contract with the Ombudsman office here in Minnesota, looking at the issues that people with hearing loss face in nursing homes. Historically, my focus has been more on people who are culturally deaf. And if that's not something you understand, please look it up. It's an interesting area of study. But those are people who use American Sign Language to communicate and share some common norms and values in their culture. This work with the nursing homes brought me more in contact with people who were anywhere from mild hearing loss to profound hearing loss, but not necessarily culturally deaf. These were people who had lost their hearing at some point in their life, did not use American Sign Language to communicate, and were now in nursing homes and the task was to look to see what the issues were that they were facing, and then to look at what potential solutions there might be to those issues. So that's a little bit about my background. So let's talk about people with hearing loss. Gosh, look at this. Nearly a fifth of all Americans 12 years or older have hearing loss severe enough that it may make communication difficult. There was an interesting thing that I heard on public radio about a year ago that said that the incoming freshmen last fall, approximately 1/4 of them had a hearing loss, again, severe enough that it made communication a challenge. I venture to guess that those earbuds we see everybody wearing have something to do with that, but we'll talk later about ways that one might prevent some of that loss. But it is one of the high-ranking chronic conditions in America. Here are just some more numbers. And I think the last point is interesting, that the hearing loss prevalence nearly doubles with every age decade. So as we all know, the older we get, the more our hearing may be challenged. For people over 75, there are some beliefs in that right column. If we look at that first, and the first one saying that hearing loss is inevitable. And I think there are those in the field of audiology who would say not necessarily true. There are things we can do to either slow it or prevent it. And others will believe that it's an inconsequential part of the aging process, and that's really our focus today, to say that's not the truth. And the other is that there's nothing we can do about it. So those are some beliefs. The facts are that people over age 75, over 50% have a significant hearing loss. I would venture to say that it's maybe a bit higher than that. What we're learning is that hearing loss is a risk factor for falls, and that it's also related to the development of dementia, and it's correlated to an increased rate of decline in persons with dementia. I'll come back and say more about those facts. So starting with falls, people with a 25 decibel hearing loss, which is a mild hearing loss, have 3 times the risk of falling. This is work that was done out of Johns Hopkins research by a physician by the name of Dr. Lin, L-I-N. And this is a statistical finding that this correlation exists, and that every additional 10 decibels of loss increases that risk 1.4 times. So gosh, something's happening here. People with hearing loss have a higher risk of falling. There was another study, and this particular one is out of Finland. It was done on female identical twins. And basically, just looking at the conclusion of it, their conclusion was that people with poor hearing acuity have a higher risk for falls. Now, part of this is what they call poor postural control. So the whole proprioception concept of where you are in space and your balance ability. And yes, auditory information is probably an important part of how we walk, how we move in space. But the interesting thing was that it was a higher risk for those twins that had hearing loss. So the twin that didn't have the hearing loss did not have the same fall risks as the twin that had the hearing loss. So people look at this research and they say, why? What causes this? Why would hearing loss increase the risk of falls? And there's speculation. There certainly is not any proof now, although Dr. Lin and others at Johns Hopkins are studying this. They're continuing their work. But the theories are people who can't hear well might not have good awareness of their overall environment. And that's something that everybody can try out for yourselves. Get some of those spongy earplugs that you use when you mow the lawn, or put the headset over your ears and just see how it impacts your ability to negotiate your environment. Also, some speculation about the cognitive load, meaning that our brain, the brain of a person with a hearing loss, may be working so hard to hear, to get those environmental cues and to hear language, that that may compromise their ability, their gait, and their balance. And as I said in the twin study, these twins had the same genetic makeup, but so they could not say that that was the reason. So really they showed that statistically it was the poorer hearing sister that had the higher risk. The other issue that Dr. Lin and his co-workers at Johns Hopkins have found is a correlation between a higher risk of dementia for people with hearing loss. And here you'll see that a mild hearing loss, which I certainly have and probably lots of you do, it doubles the risk of onset of dementia, and a moderate hearing loss triples it, and a severe hearing loss 5 times the risk. That's pretty significant, I think. Again, there are some speculations as to why. We'll look at those. The other piece of information is that for people with normal hearing who have onset dementia and people with hearing loss with onset dementia, what takes the hearing group 10 years to decline to takes only 4 years for the group with hearing loss. So that's an accelerated process. Again, asking the question why, some speculation that maybe dementia and hearing loss have some common pathology. Perhaps, again, it's that strain of decoding sounds over the years that just overwhelms the brain. Hearing loss could lead to dementia by making individuals more socially isolated. And so social isolation, we know, is a known risk for dementia and other cognitive disorders for people with normal hearing. So what might that mean for people who have a hearing loss and are even more isolated? One of the things that I like to do when I'm teaching or talking about topics is tell an occasional story. And I'd like to tell you about a woman, I'm going to call her Opal. I met her during this year that I was working in the nursing homes. Opal was in her early 90s, very sharp, very stubborn, knew what she wanted, and by God, she was going to get it. When I met Opal, it was because her hearing aids had been lost for the 3rd time. She had arrived at the nursing home with her hearing aids. They had been lost. She had insurance that covered replacement once in 5 years, so that happened, and she got her 2nd set. Then, about a year later, they were lost again, and of course there was disagreement about whose fault it was. She maintained strongly that it was the facility's responsibility and that they had lost them. A 3rd set of hearing aids appeared, and this was very concerning to me. Turned out that her roommate died and no longer needed her hearing aids, so they were put into Opal's ears, figuring that she could use them. Well, when the audiologist came to check on her, he found that the hearing aids were not hers. They were not, the molds were not made for her ears, and the hearing was not, the sound was not set for her specific loss. So the audiologist took them to Opal. That was the 3rd time losing them. What I noticed over the course of the time that I knew her was that when I first met her and this 3rd pair had just been taken away, Opal was feisty. As I said, she was sharp. She had relatives in other states that she would talk with on the phone. She had a daughter-in-law who came regularly. She was interested in talking with me. She knew other people in the facility. She knew staff and so forth. Over the course of some months, while we were fighting to get another pair of hearing aids, Opal began to deteriorate mentally. She no longer wanted to go to the common room and have coffee with other residents. She couldn't use the phone any longer. She just could not hear, even on the amplified phone. And she became more and more withdrawn. One of the times that I went to visit, there was a birthday party in the common room, which normally staff said she would go to and enjoy. And they encouraged her to go, but she said no. What was the point? She couldn't hear what was going on anyway. She became more and more depressed and withdrawn. It was sad to see, and to me, unnecessary. Unfortunately, it took us a while to fight and get another pair of hearing aids for her. The day that she got them, I visited her the next day, and I walked into her room, and she was all excited, telling me how she'd gotten her aids, and she'd called her brother in California, and she'd had coffee with a friend, and so on. To me, that was just a dramatic example of the difference it can make, and what happens when someone is isolated. Hopefully Opal's doing well. Another theory that's a newer one, and this is from a report that was published in January of this year, is brain shrinkage. Now, everybody's brain shrinks with age, but the rate of shrinkage is faster in people who are deaf or have hearing loss. They lose an extra cubic centimeter of brain a year. This was part of a longitudinal study. It was a 10-year study, and MRIs, now we've got the technology to actually see this, over 10 years found that the people with hearing, whose hearing was already impaired, had accelerated rates of brain deterioration. And the particular areas of the brain were the areas that deal with processing sound and speech. Well, that's also the part of the brain that deals with memory, and it's a part of the brain that has been seen to be involved with the early stages of Alzheimer's. So could this be contributing? We don't know for sure. This is information that's currently being gathered. Often people ask if hearing aids are the answer, and I know that we had a question ahead of time from Janet in Burlington, Vermont, who asked the question, do you think the cost of hearing aids is one reason why many adults do not seek earlier treatment for hearing loss? And yes, I believe that that's true. Cost is a huge factor, and currently insurance does not cover, most insurance does not cover the cost of hearing aids, and that's very unfortunate. I know in Minnesota, and I don't, that now that there's coverage for young people, 18 and younger, but not for adults. The question, are hearing aids the solution? I just want people to be cautious. I wear hearing aids now. I wear bilateral hearing aids. I absolutely love them. Don't want to be without them. The amount of help that hearing aids can give us may depend on the kind of hearing loss you have. If someone has a sensory neural loss that's in the inner ear or the brain, then hearing aids will amplify, but they amplify the static. I think of it like a radio. If the radio is not quite on the station and you turn it up, it's louder, but its static is louder as well, so it's not necessarily making speech more clear. For those who have middle ear type of hearing loss, which is very common with older folks, calcification in the middle ear, then this hearing aids can be very helpful. So it just depends, and that's something an audiologist can work with. There's wonderful technology now in different kinds of hearing aids, whether it's in the ear, behind the ear. There's ones that you can now focus forward, for example, so you can listen to a conversation and not be distracted by the peripheral noise as much. So it depends on that kind of hearing aid and hearing loss. And I just want people to be aware of that. I often used to hear people say, well, yeah, we got Grandpa some hearing aids, but he keeps taking them off. He won't wear them. Says he doesn't like them. And it may be because what was happening was amplifying the static and not enhancing his ability to understand voices. There are, for example, people who served in the military who have specific kind of what's called a notch hearing loss from shooting guns and having that sound close to the ear. For those people, the hearing loss is in a very specific frequency range. So they may be able to hear people with low voices, but not people with higher frequency voices. So for the wife who may have a high voice, who says, well, he just doesn't pay attention to me, but he listens to other people, it may be because that person genuinely can't hear the higher voice, but can hear a lower voice. So lots of different types of hearing loss, and one should always check with an audiologist, a qualified one. This is one of my cautions. Be careful about going to just a hearing aid company where they don't really do the in-depth testing. Go to an audiologist, get good testing, and you'll get good hearing aids. So yes, the cost is one issue. Most insurances don't cover, and those that do, if they are lost, won't necessarily pay for replacement, or they may pay for a replacement once in 5 years. The other is that people don't necessarily get the training they need to know how to use that hearing. And that's one of the things we're seeing now with cochlear implants. A lot of controversy in the field of hearing loss about cochlear implants. Those who are culturally deaf feeling that it's their language is ASL, their culture is deaf culture, why do you want to make us hearing, and so on. There are other people who believe that, gosh, if you can enhance one's hearing, why wouldn't you? I think the biggest questions are the age that cochlear implants are implanted, that we know that brain development is happening at a very early age, and so there are those who would argue that that's the time to get the implant. That controversy will probably continue, but I think given some of this new information about the shrinking of the brain, that may be some incentive to think about cochlear implants as a way to deal with that. The issue becomes that when you get a cochlear implant, anyone who has one will tell you it requires a lot of training. One of the sad moments for me, I have spent some time in Kenya, in Africa, and in the schools there for deaf children, and I found that there were several deaf children who had cochlear implants, which surprised me. And I asked about it and was told that it was a Swedish company that was providing these. I think they actually flew the children to Sweden and gave them the surgery, and then they went back to Africa. Problem was there was no one in their home country or hometown to take care of maintenance of the implant, nor to do the rehabilitative training. So really these kids just had this equipment on their heads, but it wasn't really helping them in any way. That was, to me, a sad use of resources. Another reason that some people don't get hearing aids is it's just a part of life. You get older, you lose your hearing, so what's the big deal? So those are some of the reasons, and that people don't have hearing aids. I just was handed a question here, and I'd like to address it. It came from Elizabeth Craig. Question is, when landscapers mow, trim, and cut, their equipment is very loud. How are these noise levels determined? Does OSHA have guidelines for this? And yes, OSHA does have guidelines. It has to do with a level of noise such that You may have some impact on your hearing, but by the next morning it's restored and, stays restored. When that impact is such that it may be restored initially, but after a while you never get back to the same hearing, that's OSHA's concern, and they do have guidelines for that. People definitely should wear headgear. People who work at airports, people who work with lawn equipment, anything loud like that, one should wear protection. I know I was certainly guilty as a younger person of poo-pooing the idea of putting on something when I was mowing the lawn, but I sure now wish I'd paid more attention. Very, very important. I'm sure on the website you can find exactly what OSHA's guidelines are. Thank you for that question. Let's see where we are. All right. So research is showing us a correlation between hearing loss and falls and dementia. It's not saying what the cause is or why that correlation exists. It's simply at this point saying our research shows over time that this correlation statistically exists. But if we can be more aware of it, if we can be more proactive, can we impact the increased falls and dementia? Can we, change that in a positive way? So I think hearing aids is certainly one, and one thing we all can do is to encourage people who could benefit from wearing aids to get them, but maybe more importantly to help people identify ways to pay for those hearing aids. It's been a constant battle here in Minnesota where I live to try to get the legislature to pass some kind of law saying that insurance companies need to cover the cost. Of course, we all know that the insurance companies have pretty strong lobbies, and it hasn't been particularly successful. There are some of the Medicare forms, I'm not familiar with all of them, but some of those insurances will cover at least partially, worth checking into. And otherwise, I mean, speaking for myself, I was able to get a loan and make payments on my hearing aids. And as I said before, glad I did it, wouldn't trade them for anything. The other piece is for people who do have hearing aids, they need to know, and others around them need to know, how to put them in, how to take care of them, how to check the batteries. This was one of the things that was concerning that I found at the nursing homes was, yes, people's hearing aids may be put in the morning, but nobody had checked the batteries to be sure that they were working. Putting in hearing aids with dead batteries doesn't really help. People who helped people take their hearing aids off at night, or the persons themselves, didn't know that they should open the battery chamber, that prolongs the life of the battery. The aides and nurses and the people themselves didn't realize that aids should be cleaned periodically. Things like earwax will block some of the sound from coming in. And those are all very simple things to do. I looked into our local curriculum for nursing assistants and found very little information about hearing loss and care of hearing aids. So I think that's one area that could be enhanced. I know that I would go in and do training with staff at nursing homes, but I also know that the turnover of staff is pretty rapid. So one of the last things I was working on was a online training on just how to care for aids. There's also a video that's about 10 minutes that does a good job of describing that, and I'll give you that reference at the end. So one of the things we can do is be sure that people themselves and that the people who help care for them know how to put them in. Gosh, I saw hearing aids the molds put into the wrong ears, And hearing aids have an identifying color. And I always forget, but I believe there's a little red on the one for the right ear and blue for the left ear. It's a pretty simple thing if you can remember that. What else can we do? This relates to the socialization. One of the times when I went to visit Opal at her nursing home, the aide who came in to ask her if she wanted to go to the dining room for the birthday party came up behind her. Now, you got to remember, too, that Opal had some vision loss, so she didn't see well. This person came up behind her, put their hands on her shoulder, and said, "Guess who?" Never, ever, ever, ever do that. You want to get a person's attention before speaking to them. In deaf culture, it's very acceptable to tap someone on a shoulder. Biggest thing is probably to come around in front of the person so they see you, maybe tap them, get their attention before you start speaking. Otherwise, they're going to lose everything you say until you are in that position. Make eye contact before you start speaking. And be careful about turning away. You know, somebody else says something and you turn away. Now they don't have that added lip movement to help with whatever they're hearing. Don't cover your mouth while speaking. People with bushy mustaches doesn't bode well, or people chewing gum. And it really has been a problem with a lot of the immigrant population that we have currently working in our nursing facilities. Wonderful workers, but when they're speaking English, it's often with a fairly strong accent, and any lip movement does not look the same as lip movement for a native English speaker. That can be challenging for someone with a hearing loss as well, and it can get frustrating. If somebody doesn't understand something, rephrase it. So if you say, "Did you get your medication today?" and they say, "What?" and then you say, "Did you get your medication today?" and they say, "What?" There's something in there, some sounds that they're not getting. "Oh, this morning, your pills, did someone give you your pills this morning?" Rephrase it, say it in a different way. And the other piece, and this has been the hardest to convince doctors, is allow more time. We try to tell doctors when people with hearing loss go for appointments, generally takes about twice the amount of time to get the same level of communication as with a normal hearing person. And I realize that most of our medical practitioners are under limited time things now, but try best you can to allow more time to make that eye contact and face the person when you're speaking to them. Don't be writing in the chart or typing on the computer while you're talking to them. Those are some things we can do. Some things not to do. You don't need to shout. That doesn't really help much, and it's usually rather embarrassing for the person with the hearing loss. The other piece is don't over-enunciate. That changes the shape of your lips and your mouth and makes it hard again to coordinate the lip reading and the sound that they're getting. I mentioned the Guess Who game. And of course, the worst is playing that game with somebody who's not only deaf but has vision loss as well. You always identify yourself. That's the other piece. When you get into their site and so on, say, "Hi, this is Marty, wondering if you want to go down to the lunchroom." Identify yourself. It's hard to not get impatient, and I know that's one of the struggles that family members have and friends with someone with a hearing loss. But just picture being on the other side of that and how frustrating it can be to not be understanding and know that somebody else is getting impatient with you. One of the things that I used to have my students do was to put in again those spongy earplugs and try to wear them for a full day. interesting what people say. It compromises your hearing by about 35%. It's like a mild hearing loss, really. But you'll notice all kinds of things, including the frustration of having to ask people over and over to repeat themselves. And the other piece, and this is true not only for people with hearing loss, but for many of our immigrants or people who've moved here from other countries who may not understand English well, smiling and nodding. People want to be compliant. They don't want to be a bother to you, and oftentimes, even though they don't understand, they smile and nod. Here again is one of my stories. I used to work at St. Mary's Junior College, which was next door to the old St. Mary's Hospital. And I had worked with the patient representative there to enhance his knowledge about hearing loss and encourage him to be on the lookout and so that people would get appropriate services. Well, he called me one night. He knew I taught evenings, and he called me and he said that he had found a deaf person and he wanted me to come over and analyze the situation. When I asked what the problem was, he said, well, they're smiling and nodding. So I figured I'd taught him well. I went over and I talked with the nurse and I said, you know, I understand that you're communicating fine. Oh, yes, they understand me fine. And I asked how she knew, and she said, oh, they're smiling and nodding. I went into the room. It was I say elderly deaf woman. She was probably about the age I am now, and her husband. The woman was in the bed. She was to have exploratory surgery the next day for colon cancer. They were suspecting. So I came in and I started to sign with them. They were both sign language users, and their eyes just got bright and wide. And I asked her, I said, I understand the doctor came to talk to you. She said, yes. And I said, how did you communicate with the doctor? And she signed back, well, we wrote back and forth. So I asked if she still had the piece of paper, which she did. I looked at it. Across the top in bold letters, she had written, do I have cancer? Below that, the doctor had written something to the effect of, well, this is the reason we're doing exploratory surgery in the morning, and then we'll biopsy and blah, 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 blah. I handed it back to her and I said, did you understand what the doctor wrote? She started to smile and nod, and then she stopped and started crying and said, no, I didn't understand anything. So my point being, just because somebody smiles and nods does not mean they understand. I'm going to give you a spelling test just to show you a little bit about that frustration level that can happen. I need you to turn your volume on your computers up as high as it will go as we start this, and then you can have a piece of paper and number it up to 8, or just make your list, and you're going to try to figure out what's being said. First one I'm going to give you is at one where there's some loss at the 1,000 frequency level. And different frequency levels affect different parts of speech, which is interesting. And let me interject a question here from Elizabeth. She said, my mom is unable to hear vowels in words. Is this an unusual type of hearing loss? Any way to help? And she's right. Sometimes we lose one part of speech and not the other. And yes, it is unusual. More common would be consonants, especially like the S's and SH's and the soft sounds and the sibilants, like the P sound. So the vowel sound is less common. And again, I would say have your mom looked at by a good audiologist and see. There would be hearing aids specifically that could turn up the volume for the vowels, and that may be what she would benefit from. All right, so if everybody has their volume turned up, I'm going to give you this test. Ready, set, go. I'm going to repeat number 1. I'm not sure. I didn't hear it, so I want to make sure.
Word number 1, 2.
Okay, and I want you to write down what you heard or think you heard.
Word number 2, 3.
Oops.
Word number 3, math. Word number 4, death.
Oops.
Word number 2, 3.
No, I did something wrong there.
Word number 5, snack. Word number 1.
Let's hold on 1 second here. Okay. I'm going to do word number 5 now.
Word number 5, no. Word number 6, no. Word number 7, health. Word number 8, home.
How frustrating was that? All right, now we're going to go, this will be a little better. It's a little higher frequency loss, so you can see that you'll have a little better understanding of some of the consonants and vowels. These are the same words, just a little bit easier to hear.
Word number 1, 2. Word number 2, 3. Word number 3, math. Word number 4, death. Word number 5, snack. Word number 6, milk. Word number 7, death. Word number 8,
Any less frustrating? All right, now I'm going to give you the answers, and I'll say them as well in case, well, it'll be written on the screen as well.
Word number 1, shoe. Word number 2, tree. Word number 2, tree. Word number 3, word number 3, word number 4, desk. Word number 4, desk. Word number 5, snack. Word number 6, miss. Word number 7, test. Word number 8,
So, how many did you get right? Put your number in the message thing. We'll just shoot them. We'll just see how many.
5.
And little frustrating, right? That's just to give you an idea of the frustration. And you could see that certain things like the SH and SK, Fs, those kinds of letters were hard to deal with. Okay. A few people got, somebody got 3, that's very good. Somebody got 1, several people got none. So it's pretty common, and oftentimes it'll be younger people or obviously the people with better hearing who may catch the ones. But it's kind of a fun thing, and it doesn't work real well over the internet like this, but it's still a little fun to see how frustrating it can be. There's a lot of assistive technology that I recommend to hospitals and nursing facilities, assisted living, and in your own homes. One thing is a flashing doorbell knocker. You know, in hospitals or nursing homes, how people knock at the door and then presumably they wait until someone has come in and then they go in. My experience when I was in the nursing homes was people knocked and came in. They didn't wait. And for the people with hearing loss, they most often did not hear the knock. So it can be very startling. A flashing doorbell knocker is something that's relatively inexpensive. You attach it to a door, it just hooks on, and when you knock, it flashes on a light inside the door, so the person sees the light flashing. There are listening devices like pocket talkers. If someone does not have a hearing aid, a pocket talker, either with a headset or the earbuds, and it can amplify. And I encourage you, if there's one where you work or have access to try it. You want to be very careful not to turn it up too high because it'll blow your ears out, but it can be very helpful. It's about the size of a pack of cigarettes, and so it will fit in a pocket. Kaptel phones, you've probably seen ads on TV now for Kaptel phones. If you have a hearing loss and you have to have that documented, anybody can get the phone, but you can get the phone on loan for free, and you get the service then where if you're talking to someone, it will also come up in a digital readout across the phone what the other person is saying. So if you don't catch certain sounds, you can see it. The ad I see most often is a grandmother talking to her grandchild about their soccer game, something like that. So that can be a real aid for people who can hear some but struggle with certain sounds. FM systems and infrared systems, those are used oftentimes now in churches and often in theaters. I know our Guthrie Theater here has that in all of their different theater, I can't think of the word, but I know I use it and it's wonderful. It enhances sound better than my hearing aids in that setting. I encourage that for meeting rooms, for nursing homes, hospitals. It's just, you can get it set up, or you can have a portable one that you can bring in for special situations. Flashing light alarm clocks or vibrating alarms are available. And closed captioning on televisions. This was another interesting thing where when I went to nursing homes, I noticed that the televisions in the common rooms didn't have the captioning on. And I asked about that, and the staff their reaction was, oh, well, gee, I didn't realize we could do that. When I asked some of the people with hearing loss, they said, yeah, I'd really like that. And then you'd have George who'd say, no, it covers up the football scores. I don't want that. My suggestion was have it on. Just have the closed captioning on. If there are times when someone objects, then do the democratic process and have the residents vote and decide which they would prefer. But err on the side of having them on. Why not? Just have them on all the time. You'd be surprised how many residents will benefit from that and be appreciative of that. And it's a pretty easy thing to do. I wanted to give you some sites where you can go to get more information. The first one is Deaf and Hard of Hearing Services Division. That's part of the Department of Human Services. And on their website is just a plethora of wonderful information about deafness, deaf culture, hard of hearing people, technology, hearing assistive devices, links to other resources. There's all kinds of information there that you can get. I really encourage you. And that 10-minute video that I mentioned that explains about hearing aids and talks about how to care for them can be found under the education section in this website. The one underneath that, the TED program, is part of that office, and they have adaptive equipment that they will loan indefinitely to people who have the need. So, for example, the Kaptel phones, they will loan those out to people who need them. You have to qualify financially. If you have the financial means, then you can buy your own phone. But again, if you qualify with the hearing loss, then you get that free service where someone's typing in what the other person is saying. But the TED program has other things that they loan out. They also will come out and do demonstrations of all of their equipment. Wonderful, wonderful resource, very knowledgeable people. And they have representatives around the state of Minnesota. I suspect there are probably similar programs in other states. The interpreter referral organization, if you do need to access interpreters, you can go in and check out, and you can also find that on the DHHSD website. What they will list is only those agencies that meet certain criteria, and that's important. You want to have qualified, certified interpreters if you're going to be using interpreter services. And then another website with deafblind information. Again, a whole nother area that's worthy of mega workshops. There's a wonderful, wonderful interactive course on the website that you can take to learn more about it. But it's a really, really unique population of people who have both hearing and vision loss. At this time, I would like to just see if there's anyone else who has a question that they would like to ask. I've gone through a lot of information. Let's see if we get any information here. I appreciate the questions we've had. I very much, too, appreciate this opportunity to talk with people about these issues. Each of these categories or areas of information, again, are worthy of in-depth discussion themselves. So if it's an interest of yours, contact DHHSD or the Alzheimer's Association or the Gerontological Association and ask for this kind of webinar. Oh, okay, comment here, exceptionally helpful. Thank you, Marty and Tom. Apologize, I need to jump off. Okay, thank you. How do I teach someone to speak up and enunciate rather than add attitude in their tone of voice? Personally, that's a great question, and that's for Mike. Mike Kokiller. I think the best thing is simulations. I think you put people in a room and you give them, like the test I just gave, you make them wear some kind of earplug and make them feel kind of stupid when they don't hear what you're saying. Get them to experience the frustration. I found that that's the best way. Sometimes you can lecture over and over and over again and people just don't get it, or they only remember briefly. But if they actually experience it, it can be more powerful. Comment here about hearing loss is such an under-recognized major loss, and so undereducated. People are so undereducated at all ages in our society, and you're exactly right. And we need to do something about that. I do want to mention just real quickly that Masonic Home in Bloomington, I worked with them while I was doing this project, and we collaboratively put together some stuff, and they wrote a grant for some PIP money, P-I-P-P, and I have to admit I'm not remembering now exactly, but it's money that's available for innovative kinds of studies, and they are in the process of looking at how enhancing hearing by paying attention to hearing aids and so on and educating staff, how that affects quality of life of their residents. Very excited to hear the results of that study. So with that, I say thank you very much and appreciate your attention. I hope you all have a wonderful day.
Well, I also would like to thank everyone for joining the webinar today, and I think you can understand why we picked Marty for this topic. She is a certainly an expert. And the thing that I love most is that she's a real life expert. She's been in situations that are very real and brings some common sense approach and some good information and education. Thank you so much for that, Marty. Someone asked if her slides would be available after the webinar. Yes, they will. On the MGS website, again, that's mngero.org. If you go under the webinar tab, you'll see our past webinars, and each one will have a link for the handouts for that particular webinar. I also want to address again the continuing education certificates that are available for today from either the Board of Social Work or Nursing. These are free to MGS members. They're $25 to non-members, but we would encourage all of you to join MGS for the very reasonable price of $55. And as you can see, a whole year membership is really just a little bit more than just 2 CEUs for 2 of these webinars. And then you'll get the CEUs for free for all of our webinars. You get a reduced registration for our annual conference, and you also get access to the recordings of these webinars on our YouTube channel. You can go to apply for a CEU right after this webinar ends. When you click off, your evaluation will pop up. I ask you to take just a couple of minutes to fill out the evaluation. We're very interested in what you think about today's topic, the presentation, but also some suggestions for future topics. And on that evaluation are 2 questions. One, if you are interested in CEUs, just put your name and email, and we'll get back with you on that. And then secondly, if you want to join MGS, you can also give us your name, and we'll follow up with you on that. Thank you very much for joining today. If you have any questions at all after this, you can contact us at info@mngero.org. And again, I'd like to thank Marty, and I'd like to thank all of you for attending. Have a very good day. Thank you.